Hey guys, tonight we're talking about a drug that quietly breaks a very simple assumption that people can tell when they've had enough. Most of the time, that's how it works. Not rules, not discipline, just a feeling. Something in the body that says this is enough. This is where you stop. And over time, people learn to trust it. For experienced heroin users, that feeling was the only thing standing between a normal night and a toxicology report. And when that assumption stopped working, people started dying at doses they had survived 100 times before. Nothing had changed, except one pill. Tonight we're tracing how a legitimate prescription quietly removed the only thing keeping people alive, and how the system that put it in their hands had no idea what it had done. But before we get comfortable, take a moment to like the video and subscribe, but only if you genuinely enjoy what I do here. Drop a comment telling me where in the world you're lying right now, perhaps tucked under a blanket halfway between curiosity and sleep. Now dim the lights, take a deep breath, and let's ease into tonight's journey together. Here's what nobody tells you about heroin dependence. It settles into a system. You've been using heroin long enough that the word using doesn't feel right anymore. You're managing, that's the word. Managing a thing your body now requires the way it requires sleep. Not because you want it to, but because somewhere along the way the want and the need became the same conversation, and you stopped being able to tell them apart. Tonight is a normal night. You take what you take. You feel what you feel, which is level. Not high. You stopped being high a long time ago. Level. Functional. Present enough to watch something on television, to answer a text, to exist in your own life without it being an event. The restless thing in your legs is at a 4. Your back is doing what your back does. The cost of existing is what it costs. You've done the calculation so many times you don't notice you're doing it anymore. Your body knows things, not in words, in feeling. After years of this, you've developed a kind of internal instrument, a sense for where you are, how much is in your system, where the line sits tonight. Every experienced user has it. It's not something anyone teaches you. It grows on its own, out of necessity, out of paying close attention to yourself for a very long time. There's a moment it sends a feeling, not pain, not fear, just a quiet signal like a hand on your shoulder. That's enough. Stop there. You know it the way you know when you've had one drink too many. Not after, but just before. That exact moment. It arrives, and you listen, and you stop. It has kept you here. Until a small prescribed pill called Pregabalin came along. A name that didn't sound like much, and didn't feel like much either. The warmth that comes is not what you expected. The opioid you took, the one that stopped doing much a long time ago, is doing what it did at the beginning, before your body learned to expect it, before level became the ceiling instead of the floor. Your shoulders drop. You hadn't noticed they were up. Warmth spreading from your chest outward, soft at the edges. The restless thing in your legs, gone. Your back, quiet. The low hum of vigilance that runs underneath everything. The background tension your nervous system has been maintaining for years. Lifting. You feel fine, not level. Fine. Better than fine. Better than you felt in a long time. You think, I should feel this way more often, and for the first time in a long time it doesn't feel like a bad idea. So you take a little more, not greedily, not recklessly, just, there's no reason not to. The instrument that would have said stop is the instrument that's gone quiet. You don't know it's gone. You just know that everything feels fine and there's no voice saying otherwise. You take a little more. Your breathing slows, slower than it should. Past the point your body would normally never let it reach. The part of you that monitors these things, that has caught moments like this 100 times, that has kept you here, isn't running tonight. Everything is warm. Everything is quiet. You don't feel yourself going under. That's the whole point. That's the entire story. You just feel fine. From across the room, you look calm, still, like someone who finally got some rest. Nothing about you announces what is happening. By the time something looks different, the window for moving has already closed. This is what the people who loved you couldn't understand afterward. There was no moment where you seemed to be in trouble, no sign, no reaching for a phone, no distress. You were just there, and then you were just very still. And those two things looked the same from across the room. The story of how that capsule ended up in your hand starts in a university chemistry lab in Evanston, Illinois, sometime in the early 1990s, with a man who was trying to solve a much smaller problem. His name was Richard Silverman. He is the kind of researcher who would describe himself accurately as methodical. He worked in a field called medicinal chemistry, which is a polite way of saying he spent his career taking molecules apart and putting them back together differently to see if they did something more useful. His handwriting was almost certainly legible. He almost certainly had a system for his filing. In 1990, he was researching anticonvulsants, drugs to prevent seizures in people with epilepsy. The target was a neurotransmitter called GABA, which is the brain's primary calming signal, and he was exploring structural variations of drugs that acted on it. He wasn't looking for Pregabalin. He was looking at a region of chemical space, and Pregabalin was one of several hundred compounds that emerged from that exploration. It was noted, filed, and sent off for development. Silverman would eventually receive royalties worth hundreds of millions of dollars from the drug he made in 1990 while looking for something else. He donated most of it to Northwestern, which is not the plot twist anyone was expecting, but there it is. The compound passed through corporate hands the way valuable things do, quickly and profitably. Park Davis picked it up first, then Warner Lambert acquired Park Davis. Then Pfizer acquired Warner Lambert in 2000, in what was at the time the largest corporate merger in history. They got several drugs in the deal. The one that mattered most turned out not to be the one anyone was paying attention to. Pfizer named it Lyrica. The name was deliberate, lyric, musical, something that suggested gentle relief rather than pharmaceutical intervention. They are good at names. They are, as a company, extraordinarily good at names. European approval came in 2004 for nerve pain and epilepsy. American approval in 2005. Then, in 2007, the FDA approved it for fibromyalgia, which was a move of some commercial genius because fibromyalgia is common, painful, poorly understood, and until that point had no drug specifically approved to treat it. For Pfizer, the fibromyalgia approval wasn't a medical milestone. It was a business opportunity that had been sitting there in pain for years, waiting for someone to notice it. The EMA, the European regulator, also approved it for generalized anxiety disorder in 2008. This was an approval the US never granted, which meant that in Europe, and specifically in the United Kingdom, a doctor could prescribe Pregabalin for anxiety with full regulatory blessing, and prescribe it they did. By 2018, Lyrica was generating $5 billion per year for Pfizer. That number is worth sitting with for a moment. $5 billion per year from one molecule that Richard Silverman synthesized in 1990 while he was looking for something else. Now, Northern Ireland. There's a way of describing Northern Ireland that involves the mountains and the coastline and the linen industry and the literature, and none of it is wrong, and none of it is what we need to understand this story. What we need to understand is this: 30 years of armed conflict, ending formally in 1998, leaves behind more than just peace. It leaves behind something the peace process didn't schedule a session for. The sessions ran out before they got to the trauma, before they got to the generation of people who grew up watching their neighbours disappear, who learned young that the sound of a car backfiring meant something specific, who came back from funerals that shouldn't have happened and filed it away in the only place the human brain knows to put what it can't process. Rates of PTSD in Northern Ireland are among the highest in Europe, not among former combatants specifically, in the general population. Mental health services, in 2010, had waiting lists that stretched to 2 years and beyond. The NHS was doing what it could, which was also not quite enough. GPS in North Belfast and East, Belfast and Derry were running appointments that lasted 9 minutes, and writing referrals that went onto lists that would take years to clear. Into this particular context, Pregabalin arrived, approved for anxiety, cheap, fast-acting, available on the NHS prescription form, starting to work within days. For patients with genuine, documented, clinically diagnosable anxiety disorders, of which there were a very large number in Northern Ireland, Pregabalin was not a mistake. It was medicine. It worked. Thousands of people took it and found their days less terrible. The drug was doing exactly what it was supposed to do. The complication was structural, not malicious. Because Northern Ireland in 2010 was also a place with a heroin problem. Not the largest heroin problem in the UK, not the most visible, but concentrated. Specifically in certain estates in South and North Belfast, in communities where the economic disruption of the post-conflict period had settled unevenly, where the industries that had once employed entire streets had long since moved on, and where the population that remained had discovered, through the usual underground channels, that heroin quieted things in a way that nothing else available could. Heroin dependence creates a specific kind of anxiety, not the anxiety you started with, though that's still there, a new anxiety, the anxiety of needing, the body's demand, becoming louder over time, for the thing that has become its reference point for okay. Between doses, opioid-dependent people live in a state of low-level dysphoria that is genuinely unpleasant and genuinely physiological. It's not weakness, it's chemistry. The brain has recalibrated its baseline, and ordinary life, unstimulated, unprompted ordinary life, now registers as a kind of deficit. Pregabalin addressed this, not by design. Not because anyone sat in a meeting at Pfizer and said, "This would work well for heroin-dependent people with interdose anxiety." Nobody said that. But opioid-dependent people in Northern Ireland figured it out through the most efficient research methodology known to human beings. Word of mouth, within a community where people are trying to survive. The drug was cheap, it was legal, it came in a foil blister pack, and it made the heroin feel better. That last detail matters in a way the others don't. When people in opioid-dependent communities describe why they combined Pregabalin with heroin, the most common explanation is not that they wanted a better high. Most of them had been using long enough that the high had become secondary to the management. What they wanted was for the anxiety to stop, for the gap between doses to become bearable. That was the main thing. But Pregabalin also, as a secondary effect, appeared to enhance the opioid, made it feel more complete, smoother, required less of it to produce the same effect. For people who had spent years carefully calibrating their doses, who knew their tolerance down to a fairly precise internal measurement, this was not nothing. Less heroin for the same result is, from a harm reduction standpoint, a reasonable goal. From a risk standpoint, it meant the dose that felt right was now being calculated against a baseline that Pregabalin had moved without announcing it. This is the part where it becomes useful to understand something about experienced heroin users that doesn't appear in the leaflets or the public health campaigns. They are careful. Many of them are extraordinarily careful. After years of use, people who use heroin regularly develop what researchers who work with them describe as a survival intelligence. Physical knowledge, bodily knowledge, an internal signal that says, "Here, don't use more, something isn't right." It grows on its own, out of necessity, out of paying close attention to yourself for a very long time. It's not infallible, but it works. It has kept people alive. Pregabalin, it turned out, was very good at switching it off, not by producing distress, not by making you feel ill or wrong or like something had gone wrong, the opposite. Pregabalin quieted the whole system. The excitable neural signaling that produces the body's warning cries, including the ones that say, "Stop now, something is off," calmed down along with everything else. The alarm went quiet. The user had no way of knowing. There was nothing to notice. The silence didn't announce itself. They continued as they normally would. They waited for the signal. It didn't come. The capsules themselves are worth describing because the detail matters. Pregabalin comes in hard capsules, white or off-white depending on the dose. The 150 mg capsule is typically marked with the dosage and the manufacturer's name. When dispensed on the NHS, they come in a foil blister pack with the patient's name on the label, the prescribing doctor's name, the pharmacy's name, and the date dispensed. They look like medicine. They are medicine. This is what made diversion so frictionless. There was no paraphernalia, no syringes, no tinfoil, no ritual. You pressed a capsule out of a blister pack and swallowed it. The same action you'd take with a vitamin or an antihistamine. Completely unremarkable. A prescription of 25 capsules at 150 milligrams, a fairly standard initial prescription, was worth, on Belfast streets at the time, roughly £25. £1 per 100 milligrams. At a time when a gram of heroin was running £50 to £60, this was not a fortune, but it was enough to make diversion routine. The person the prescription was written for might take some of them. The rest would travel to a friend, a neighbour, someone in the same network. No drug deal required, just sharing, the way people share things in communities that have learned to share what helps. The blister pack changed hands. The capsules left the pack. The name on the label stayed in. The pharmacy records as a patient whose prescription had been dispensed. Street-level Pregabalin was reaching opioid-dependent communities in Belfast in numbers that the prescribing data alone couldn't account for. This was not a mystery. This was how diversion works. Every NHS prescription is a potential source, and Pregabalin was being prescribed widely to a population with significant anxiety burden in a city where opioid dependence was concentrated in specific, close-knit communities where news travels. The drug was available, it was affordable, it worked for what people were using it for, and nobody had told them what it does to the alarm. Not the GPs, they were prescribing for anxiety, not opioid combination. The interaction was in the pharmacological literature, but not on the patient information leaflet in plain language. Not the NHS pharmacy, the dispensing pharmacist checks for obvious contraindications, not for a patient's off-prescription use habits, not public health campaigns. Pregabalin was not, in 2012, a drug anyone was warning people about. It was a prescription medication. It had a name on the blister pack. It looked safe. It came from a doctor. There is a structural reason the warning didn't exist in a form that could reach the people who needed it. Pregabalin's clinical trials, the studies that produced the safety data, the contraindications, the prescribing guidance, were run on people with neuropathic pain, fibromyalgia, epilepsy, and anxiety. This is how clinical trials work. You test the drug on the population you're seeking approval for. You measure safety in that population. You publish the results. The population that would combine Pregabalin with heroin was not in those trials. Including them would have required testing a pharmaceutical drug on people actively using an illegal substance. Ethics committees do not approve this. Regulatory bodies do not require it. So the interaction, the specific lethal quieting of the opioid user's alarm system, was not in the trial data. The mechanism was understood pharmacologically. Any researcher who looked at the calcium channel literature and thought about opioid-dependent nervous systems could have predicted the risk. Some did. The prediction existed in academic papers. Academic papers are not on the blister pack. In a community that had learned, through entirely reasonable historical experience, to be deeply skeptical of official drug warnings, a community where the government's relationship to honest information about drugs had not always been a distinguished one. The one source of information people might actually trust was the source that said, "This was prescribed. This has a doctor's name on it. This is medicine." That source said nothing about the alarm, because nobody had told that source either. The first systematic documentation of what was happening was not a public health announcement. It was not a newspaper investigation. It was a series of toxicology reports, written in formal technical language, accumulating in the office of John Leckie. John Leckie was Northern Ireland's state pathologist and then its coroner, a man whose job is to understand the physical fact of how people die, which requires a particular temperament, not cold exactly, but steady. The kind of person who can look at evidence without flinching and document what he finds. What he was finding from roughly 2012 onwards was this: heroin and pregabalin, both in the toxicology, both at doses that, in isolation, fell within ranges associated with survival. Not enormously high doses, not dramatic overdoses. Doses that, taken separately, people had survived before. Together, they were not surviving. The language of a toxicology report is precise by design. It does not say, "This combination killed this person." It says, "Substances detected at the following concentrations." It notes whether those concentrations are within or outside typical therapeutic ranges. It documents. The interpretation, the what this means, the why this keeps happening, is the coroner's job. Leckie was interpreting, and what he was interpreting case by case was a pattern so consistent it had stopped looking like coincidence and started looking like mechanism. Young men mostly, people who had been using heroin for years without dying, which means people who knew what they were doing and had survived on that knowledge. People who had apparently done nothing different on the day they died, except for the capsule, the one that came in the foil pack, the one that looked like medicine. He wrote it up, formally, carefully, in the language that coroners use. He submitted the reports to the Department of Health in Northern Ireland. He called, explicitly, for regulatory attention on gabapentinoids, not as a side note, not buried in a footnote, but as the central finding stated directly. Most coroners document and move on. Leckie documented and came back. The reports were received, they were filed, the appropriate departments were informed. Everybody in the chain was doing what the chain required. The chain was moving at the speed chains move. Meanwhile, in pharmacies across Northern Ireland, prescriptions were being dispensed. Blister packs were changing hands. And somewhere in South Belfast, in a house on an estate where the street used to have more people on it, someone was pressing a white capsule out of a foil pack and swallowing it, and waiting for the anxiety to quiet, and not knowing that the thing that was about to quiet was the thing keeping them alive. There's a version of this story where that's the end of the picture, where what happened in Northern Ireland is a local problem, specific to a specific geography, a specific post-conflict legacy, a specific history. It was not. Scotland was having the same conversation. Different city, different housing estate names, different accent on the phone calls to the coroner's office. Same toxicology. Scotland in the early 2010s already had the highest drug death rate in Western Europe. This was not a new problem. It was a long problem, rooted in the same structural conditions that tend to produce drug crises everywhere. Deindustrialization, poverty, overwhelmed services, and a population of people who had found in heroin a solution to conditions that had no better solution on offer. Glasgow specifically had been managing a heroin crisis for decades. The city knew what overdose looked like. Except now overdose was looking different. The toxicology was returning with 2 substances rather than 1. Neither in isolation at lethal concentration, together past the threshold. And the pattern was appearing with a frequency that clinical staff in Glasgow addiction services began talking about, in the way that clinical staff talk when they know the paperwork won't catch up to the reality for a while yet. Gabapentinoids, Pregabalin, and its slightly less potent relative gabapentin were being found in a growing proportion of Scotland's drug deaths. By the middle of the decade, they were present in the majority of them. Scotland was recording this data. The data was going to government reports. The government reports were going to committees. The committees were going to review processes. The review processes would eventually produce a recommendation. They just hadn't gotten there yet, not even remotely close. There's a form that every general practitioner in the United Kingdom fills out when they prescribe a controlled or commonly prescribed medication. It isn't complicated. Name of drug, dose, duration, quantity, sign at the bottom. The pharmacist reads it, dispenses it, scans the barcode, and hands the patient a paper bag. The form doesn't have a field for where is this going after it leaves the pharmacy? It couldn't. That information doesn't exist at the moment of prescribing. The GP knows the patient in the chair. They know the symptoms, the history, the response to previous medications. They don't know the network. They don't know who the patient will see on the way home. They don't know that the street 2 minutes from the pharmacy has a concentration of heroin-dependent people who have been passing around the news that Pregabalin makes the whole thing more manageable. That's not a failure of the form. It's just what the form is for. The prescription wasn't a mistake. That's the thing that makes this story harder than it looks. A GP in Northern Ireland in 2012 had a waiting room full of people with anxiety, pain, and trauma-related conditions, and a referral system that wouldn't see most of them for 2 years. Talking therapy, 18 months, if the patient scored high enough to qualify. The pain clinic, 6 months just for someone to look at the problem. The SSR is she might otherwise try, 6 weeks before anything happens, preceded by 2 weeks of nausea that most people interpret, reasonably, as the medication making them worse. Pregabalin worked in days, approved for exactly this. Reimbursed by the NHS, already in her prescribing system waiting to be clicked. The rational choice made itself. She had no particular reason to ask what the patient planned to do with a blister pack on the way home. That question wasn't on the form. It wasn't in the guidelines. It hadn't occurred to anyone to put it there yet, because it really did work. This part matters, and it gets lost sometimes in the version of this story that's told in retrospect, when the outcome is already known and the hindsight has settled in. Pregabalin is not a bad drug. It is not a drug that shouldn't exist. For people with diabetic neuropathy, the burning, shooting nerve pain that comes with long-term diabetes that feels like something electrical and wrong is happening under the skin, Pregabalin often provides the first meaningful relief they have had in years. For people with fibromyalgia, a condition that for a long time wasn't taken seriously as a diagnosis, and for which there had been no specifically approved treatment, it was something close to a landmark. For people with epilepsy who hadn't responded well to other anticonvulsants, it gave them back days that would otherwise have been swallowed by seizure management. And for people with generalized anxiety disorder, the kind that isn't dramatic, that doesn't arrive with panic attacks or obvious triggers, that is just a constant low-level state of wrong that makes every ordinary task slightly heavier than it should be. Pregabalin quieted it in a way that felt to many of them like a first breath of actual air. It worked. The drug that was showing up in toxicology reports in Belfast was the same drug that was giving someone in Glasgow the first full night's sleep they'd had in 4 years. Same capsule, same foil pack, one story, 2 completely different endings. The drug wasn't the variable, the combination was. Northern Ireland had, by the early 2010s, one of the highest rates of Pregabalin prescribing in the United Kingdom. This was not an accident. It was a consequence of the specific health burden of a post-conflict population, combined with a prescribing infrastructure that had been correctly informed that Pregabalin was the approved, evidence-based treatment for anxiety and neuropathic pain, both of which were present in this population at elevated rates. GPs were doing what the evidence told them to do. The evidence was not wrong. But prescribing rates at that density have a structural consequence that is almost mechanical in its logic. A drug prescribed to, say, 1 in 50 adults in a given postcode doesn't stay exclusively in those hands. People share things. People sell things. People give things to relatives. In communities where money is tight and pharmaceutical relief is valuable, a prescription has a secondary market that operates independently of the healthcare system that generated it. The arithmetic of diversion isn't complicated. If 20,000 people in Belfast are receiving Pregabalin prescriptions on the NHS, and even 5% of those prescriptions are partially or fully diverted into secondary use, that's 1,000 prescriptions worth of Pregabalin moving outside the system. In a city of 350,000 people, 1,000 diverted prescriptions produces a street supply that is reliable, affordable, and legal enough in appearance that nobody handling it feels they're doing something obviously dangerous. It came in a foil blister pack, with a name on it. This is diversion without drama. No criminal operation, no supply chain, no middleman taking a cut. Just a healthcare system generating a reliable supply of a drug into communities that had a use for it, one prescription at a time, with no mechanism for noticing. Because the mechanism for noticing would have required the prescribing database and the street-level reality to talk to each other. They did not talk to each other. Pfizer, meanwhile, knew. Not in a way that suggests a boardroom meeting where someone said, "Let's keep selling this while people die." That's not how this works. That's never how this works. And believing it works that way lets the actual mechanism off the hook. What Pfizer knew, through their pharmacovigilance systems, through regulatory filings, through reports submitted by healthcare providers in multiple countries, through the standard surveillance infrastructure that large pharmaceutical companies maintain because they are legally required to, was that Pregabalin was being misused in opioid-dependent populations in the United Kingdom. This was documented. This was in their systems. The earliest signals were appearing by 2010 at the latest. Their response when the Advisory Council began its review was a response that pharmaceutical companies give. The drug helps legitimate patients. Reclassification would harm those patients. Access is important. Any measure that restricts prescribing needs to be balanced against therapeutic need. None of this was dishonest. All of it was also being said by a company for whom Lyrica represented at its peak around 1 in every $14 of total annual revenue. Pharmaceutical companies are not charities. They are not obliged to be charities. They exist to generate returns for shareholders, which requires protecting revenue, which makes advocating against regulatory action that would reduce prescribing volumes an entirely rational corporate behaviour. The people making these arguments were not villains. They were doing their jobs inside an incentive structure that pointed in a particular direction. That direction happened to point away from the coroner's office in Belfast. John Leckie had, by 2013, seen the pattern enough times that it had stopped being a coincidence and become a finding. The language of toxicology is careful by design. It doesn't say this combination killed this person. It says substances detected at the following concentrations. It notes whether concentrations are within or outside typical therapeutic ranges. It documents. The interpretation, what this means, what killed whom, is the coroner's job. Leckie was interpreting 2 substances, heroin, Pregabalin. both within or near concentrations that the literature associated with survivable use. Together, fatal respiratory depression. The mechanism was pharmacologically intelligible, the calcium channel effect of Pregabalin suppressing the CNS signals that would otherwise have produced distress. The breathing slowing, no alarm, no stop signal. He was seeing this pattern in cases that were, individually, heartbreaking in their ordinariness. Young men in their 20s and 30s, people who had been using heroin for years without dying, which means people who knew what they were doing and had survived on that knowledge. People who had apparently done nothing differently that day, except add a capsule that came in a foil pack and looked like medicine. He wrote reports, formal, thorough, appropriately measured in their language. He flagged the pattern to the Department of Health in Northern Ireland. He called, explicitly and repeatedly, for regulatory action on gabapentinoids. He continued to receive new cases. The reports were received. They were filed in the appropriate place. The appropriate processes were informed. The wheels of institutional response began turning at the speed institutional wheels turn. When the problem is real but complex, the evidence is accumulating but not yet a crisis in the political sense, and the drug in question is a legitimate pharmaceutical with a powerful advocate in its manufacturer. The wheels turned, and then there were the families. This is the part of the story that doesn't appear in the regulatory submissions or the pharmacovigilance reports. The part that exists in kitchens at 6 a.m. and phone calls that begin, "I need to tell you something," and rooms in houses that stop being rooms and start being places where something happened. The families of the people who died began to notice, in the way families notice when they're talking to each other at funerals and in waiting rooms, that the deaths had a particular quality. That the person who had died, the son, the brother, the partner, had not looked distressed, had not looked like they were in pain, had looked, by most accounts, peaceful. This is one of the cruelties specific to this kind of death. With most drug overdoses, there are signs. The body's response to respiratory depression includes distress, the diaphragm working harder, the face changing, something visible that says this person needed help. Family members and friends who have found people in overdose situations have sometimes been able to intervene. The naloxone programs that exist in communities with high opioid use depend on this, on the idea that overdose has a window, a visible moment, where reversal is possible. Pregabalin removed that window, not by killing faster, by killing silently. The breathing slowed without distress. The body didn't struggle. There was nothing to see. Family members found people who looked, in the words that came up again and again in accounts from this period, like they were sleeping. The blister pack was usually still nearby. The foil strip, some capsules, pressed out, the NHS prescription label still attached with the patient's name and the date dispensed. The GP who wrote the prescription hadn't done anything wrong. The pharmacist who dispensed it hadn't done anything wrong. The person who died hadn't done anything that they'd been specifically told was dangerous. This is the thing that the regulatory process wasn't designed to handle quickly. The harm had been distributed so evenly across so many rational individual decisions that there was no obvious single point of failure. Just a drug, and a combination, and a gap between what the system knew and what it had managed to communicate downward to the level where people were actually dying. Lecky's reports sat in the correct folders. The Department of Health was aware. The Advisory Council on the Misuse of Drugs had not yet been formally asked to look. What was happening in Belfast was happening at the same time in living rooms in Glasgow's East End, in estates in Lanarkshire, in flats in Dundee. Scotland's heroin problem was older, and in some ways more entrenched than Northern Ireland's. Glasgow had been managing a heroin epidemic since the 1980s, a crisis rooted in deindustrialisation, concentrated unemployment, and the particular despair that settles into a city when the thing that gave it its purpose and its economy leaves over the course of a decade and does not come back. By the time Pregabalin became widely available, Glasgow's opioid-dependent population had decades of survival intelligence built up. They had seen drugs come and go. They had seen the government respond. They had mostly learned to distrust the official version of what was dangerous, because the official version had been wrong before, and the cost of trusting it had been paid by people they knew. What they hadn't been told, what nobody had told them, was the particular thing that this drug did. Not that it was pleasurable, not that it was addictive, although it was. Not the general warning label language about combining with other CNS depressants. The specific functional bodily reality that if you took it alongside heroin, the signal that kept you alive would go quiet. That information would have been actionable, a direct warning from a trusted source about a concrete mechanism. People who use drugs make risk calculations constantly. They are, on the whole, more sophisticated about risk than the public information campaigns aimed at them tend to assume. But they can only calculate the risks they know about. Nobody had told them about this one. The reports were in the system, the pattern was documented, the pharmacovigilance data existed, the coroner was writing. And somewhere in the space between that documentation and the communities where people were dying, the information simply didn't travel. Not because of malice, not because of conspiracy, because the pipes that connect formal institutional knowledge to the people who most need it run at institutional speed through institutional channels in institutional language, and the people who most needed this information were not reading regulatory filings. By 2014, Public Health England had published data showing rising gabapentinoid presence in drug deaths in England and Wales. Scotland's own data was tracking in the same direction. Northern Ireland's coroner had been flagging this for 2 years. The picture was becoming visible if you were in a position to see it. If you had access to the data, if you read the reports, if you attended the conferences where addiction medicine specialists were beginning to compare notes. The picture was not visible to the person in the flat in Parkhead who had run out of their own prescription and was buying capsules from a neighbour who had a few spare. The distance between those two positions, between the researcher at the conference and the person in the flat, is not a distance that regulatory rescheduling alone was ever going to close. But it was the only tool that was coming. The Advisory Council on the Misuse of Drugs is a body that does not move quickly by design. This is not a criticism. It is a structural description. The Council exists to provide evidence-based recommendations on drug policy to the Home Secretary. Its members are scientists, clinicians, criminologists and public health specialists. They gather evidence, they review submissions, they hear from stakeholders, which means, in practice, from pharmaceutical companies, from patient advocacy groups, from addiction specialists, from coroners, from community organisations. The process is designed to be thorough because drug rescheduling has consequences. Making a drug harder to obtain affects the people who legitimately need it. A drug scheduled too hastily on insufficient evidence can cause genuine harm to genuine patients. The Council has seen this go wrong before, so it moves carefully. In 2015, it was formally asked to look at gabapentinoids. It gathered evidence from patient groups, addiction specialists, coroners, and, this being standard practice, legally expected, entirely normal, the manufacturers of the drug under review. Pfizer submitted evidence. This is how the process works. It is also structurally a situation where the company generating $5 billion a year from the drug has a seat at the table where the drug's future is being decided. Nobody designed it this way to cause harm. It is simply what stakeholder consultation means when one of the stakeholders has shareholders. This was 3 years after Leckie had filed his first formal flagging, 3 years after the pattern had appeared clearly enough in Belfast toxicology to be identified as a pattern rather than a coincidence. 3 years, 3 years. In those 3 years, the prescribing data shows that Pregabalin dispensing in the UK continued to rise. In Northern Ireland, it rose faster than the national average. The number of prescriptions written annually across England, Scotland and Wales climbed year on year, reaching tens of millions of individual prescriptions by the mid-decade. A drug dispensed tens of millions of times per year is not a drug that stays within the population it was prescribed to. The mathematics of leakage are not complicated. Nobody was doing anything wrong. The GPs were prescribing appropriately. The pharmacists were dispensing correctly. Pfizer was manufacturing and distributing a drug that had been approved by every relevant regulator. The Advisory Council was conducting a thorough review. The Department of Health was receiving and filing the coroner's reports. Everyone was doing their job. The thing that was killing people fell in the gaps between those jobs. The first time many people outside the affected communities heard about Pregabalin and heroin was in a newspaper, roughly 2015 or 2016, in a story that followed a pattern that drug-related harm stories tend to follow. A family, a death, a photograph of a person who died young, a quote from a mother who said her son had not known the drug was dangerous. He hadn't known. That was the thing. Not a secret he'd been keeping. Not a risk he'd decided to take knowingly. He had, like most people in his situation, been making decisions based on the information available to him. Pregabalin came from a pharmacy. It came in packaging with a name and a dosage and a doctor's signature. The signal that something was dangerous. The signal that accompanied other kinds of harm. The signal that told you you'd gone too far. This drug specifically removed that signal. He hadn't known. The question of who should have told him, and when, and how, and through what channel, that is the question that the regulatory process was attempting to answer at exactly the moment he was not being told. The reports were correct. The data was accumulating. The council would, in 2017, issue a recommendation for reclassification, and the government would act on it, and the drug would become Class C in April 2019. But that was 2019, and this was 2014, and 2015, and 2016. And the prescriptions were still being written, and the blister packs were still changing hands, and the alarm was still going quiet in rooms where nobody was watching, in moments that left no trace except in the formal language of a toxicology report that would eventually reach a desk in Belfast and be read by a man who had already read too many of them and be filed. It's worth pausing on something that tends to get flattened in retrospective accounts. The people who were dying were not the people the public health campaigns had prepared anyone to worry about. The stereotyped image of a drug overdose death, the image that government messaging had spent decades constructing, was someone reckless, someone chaotic, someone making obviously bad decisions in obviously dangerous circumstances, someone, implicitly, who had brought something upon themselves. The people dying from the Pregabalin and heroin combination didn't fit this image. They were experienced. Many of them had been managing heroin dependence for years, in some cases decades, with a functional precision that outsiders might not recognize as precision, but that it undeniably was. They knew their tolerance, they knew their suppliers, they knew the difference between a manageable dose and a dangerous one, because they had built that knowledge through survival. They were, in the specific sense that matters here, careful, and the drug that killed them was not one they'd scored from a stranger in a car park. It was one that had arrived in their community through the healthcare system, prescribed by a GP, dispensed by an NHS pharmacy, with a label that listed the prescribing doctor's name and the date and the instructions, take as directed. It looked like medicine. It was medicine. For the GP who prescribed it, for the pharmacist who dispensed it, for the patient who received it, and then shared it or sold it, everyone in that chain had been acting on the assumption that a drug approved for anxiety, dispensed by the NHS, was not going to be the thing that killed someone. That assumption was not unreasonable. It was wrong. And by 2016, the coroners of Northern Ireland and Scotland had assembled enough evidence that it was wrong to fill a filing cabinet. The filing cabinet was in the right building. The information was in the right format. The people who needed to act on it had received it. They were working on it. Here's the thing about institutional response time. It is not experienced as delay by the institution. Within the Advisory Council, within the Department of Health, within Pfizer's Regulatory Affairs Division, within the NHS commissioning bodies that tracked prescribing data, everyone was doing what they did, attending meetings, writing papers, preparing submissions, awaiting responses, scheduling follow-up. From inside these processes, this is what thoroughness looks like. From the window of a flat in North Belfast in 2016, where someone's son had just died in a way that looked peaceful and didn't fit any of the overdose warnings anyone had ever given the family, it looked like something else. It looked like nobody had heard. The coroner had heard. The public health researchers had heard. The addiction medicine specialist had heard. The Advisory Council was in the process of hearing. The family hadn't heard. Their son hadn't heard. The network of people who would continue to combine these two drugs in good faith while the review concluded hadn't heard. And in that gap, between the formal institutional hearing of a problem and the community-level knowledge of it, the weeks kept passing, and the prescriptions kept being dispensed, and the reports kept landing on Lecky's desk. The reports are sitting in the Department of Health right now. The data is in the files. The Advisory Council is gathering its evidence. Pfizer's regulatory team is preparing its submission. And in a pharmacy somewhere in Glasgow, a prescription is being filled. The capsules go into a bag. The bag goes across a counter. The person receiving it walks out into the kind of afternoon that doesn't announce itself as significant. The ACMD won't publish its recommendation for another year. Scotland's drug deaths don't look like England's. They don't look like anywhere else in Europe's, for that matter. Scotland has, for most of the past 2 decades, maintained the highest drug death rate on the continent, a statistic that gets cited in public health literature and parliamentary debates, and then filed alongside the other statistics that are regularly cited and not fixed. The causes are the usual ones that accumulate in places where the economy left, and the services didn't arrive to fill the gap. Poverty, concentrated unemployment, a heroin epidemic that took hold in the 1980s and never fully let go. By 2017, gabapentinoids were present in the majority of Scotland's drug deaths. Not a plurality, not a notable proportion, the majority. The figure that arrived in 2018 for the preceding year's drug deaths was 1,187. In one country of 5 million people, in 1 year. The arithmetic that does something to you. If gabapentinoids were present in 55% of those deaths, which is what the data showed, then you're looking at approximately 650 people who died with pregabalin or gabapentin in their system, alongside something else. 650 is a number that resists being held in the head as a number. It keeps trying to become faces, specific rooms in specific flats, specific phone calls at specific hours of the morning. Scotland's per capita drug death rate was, by this point, around 3 times the European average. The comparison countries, Portugal, Germany, the Netherlands, were not doing everything right. They just weren't doing it this wrong. The toxicology reports from Belfast and Glasgow were, by 2015, telling a story clear enough that anyone reading them in sequence would have seen the pattern within minutes. The pattern was not subtle. It was the same pattern, repeated across cases with different names and different addresses and different histories, all sharing the same 2 substances in the same configuration, heroin and pregabalin, in almost every case, both at concentrations within or near the range the literature associated with non-fatal use. In almost every case, together, fatal. The mechanism was pharmacologically consistent. The calcium channel suppression removing the distress signals, the breathing slowing past the threshold without producing the alarm that would have made the slowing visible to the person experiencing it. The coroners in Belfast and Glasgow were reading these reports individually. They were also, at conferences and in correspondence with public health colleagues, beginning to read them collectively. The picture that emerged from collective reading was not ambiguous. It was a drug combination that killed people who would otherwise have survived. And the drug in that combination was being prescribed on the NHS at tens of millions of prescriptions per year in communities with elevated rates of opioid dependence by GPS who had been given no guidance about this particular interaction. This is the moment in the story where, if it were a different kind of story, someone would have walked into an office and said, "Stop. We need to stop this now." Nobody walked into an office and said that, not because nobody cared, because the people who understood the pattern were scientists and coroners and addiction medicine specialists, and the people with the authority to stop it were legislators and regulators, and the distance between those two groups, in terms of institutional culture, reporting channels, and the speed at which formal evidence moves through formal systems, is not a distance you cross by walking into an office. You cross it by filing reports, and waiting, and filing more reports. Leckie filed reports in 2012, and 2013, and 2014, each one careful, each one formal, each one saying the same thing in slightly different clinical language. This pattern is not random. This combination is killing people. This requires regulatory attention. Each report was received. Each report was filed. Each report was, in the language of institutional process, acted upon, which meant it was read, summarized, passed to the appropriate department, and placed in the queue of evidence that would eventually reach the body with the authority to act. The queue moved at the speed of evidence-based policy. The deaths moved faster. The Advisory Council on the Misuse of Drugs issued its recommendation in 2017. Pregabalin and gabapentin should become Class C, Schedule 3. Physical prescription required, 7-day supply maximum, no telephone repeats. The recommendation was correct. The evidence supported it. The process that produced it was legitimate. It had begun in 2015. The recommendation arrived in 2017. Action would be taken in 2019. Between the first formal flag and the enacted law, 7 years. The survivors are the people this story doesn't usually know what to do with. People who used heroin and pregabalin together and are still alive, because the dose happened to be slightly lower, because someone found them, because something intervened, carry in their accounts an account of the experience that the toxicology reports can't provide, because toxicology reports are written by people reading the outcome, not living inside the moment. The accounts go roughly like this. You've used heroin before, many times. You know what it feels like to go slightly too far. There's a quality to it, a set of physical signals your body produces when the dose is approaching the edge. A heaviness that isn't quite the good kind. A sense of something being wrong that's distinct from the high. You've learned to recognize it. You stop when you feel it. You don't feel it. You're aware that you've used, that you're high, that everything is calm. You're not aware that your breathing is slowing in the specific way that it's slowing. There's no signal that something is off because the drug that produces the signal has been quieted alongside everything else. You don't feel it happening, is how one person described it to a researcher documenting the pattern in Glasgow. That's the thing. You're just there, and then you're not. The ones who could describe it were the ones who had someone nearby to call an ambulance. The ones who were alone left only the toxicology. What the survivors also described, and this is the detail that addiction medicine specialists found most clinically significant, was the absence of any retrospective awareness that something had been different. With a normal near overdose, people wake up knowing something went wrong. Their body has gone through something and the memory of it is there. With Pregabalin in the combination, several survivors described waking up with no sense that anything unusual had occurred, no physical memory of distress, no warning registered anywhere. The alarm hadn't just gone quiet in the moment. It had left no record of having been there at all. The families who began speaking publicly in 2015 and 2016 shared something beyond grief. They shared a particular confusion about what they were supposed to feel. Most drug-related deaths produce a narrative that, whatever its accuracy, gives families something to work with. The drug was dangerous. The person knew it was dangerous. This is the story drug prevention campaigns had spent decades constructing. It provides a framework. It names a villain. It offers, however unjustly, somewhere to put the anger. The Pregabalin deaths didn't fit this story. The drug had come from a pharmacy. It had a name on the label. The GP had prescribed it. In some cases, the person who died had been taking it as instructed. Their own prescription, their own dose, with a drug they had been using for years alongside it. No one had told them these two things, combined, were specifically distinctly dangerous in a way that neither alone was. The families who spoke to journalists described this. Not the anger at a drug they'd expected to be dangerous, but the bewilderment at a drug that had looked safe. The blister pack still on the table, the doctor's name still on the label, the death that looked peaceful in a way that wasn't comfort but its own cruelty. Because it gave them no visible moment where something could have been different. Where was the warning? There wasn't one. Not one that reached them. The information existed in pharmacovigilance databases and academic papers and coroners' formal submissions. It was in the system. The system was a different place than the kitchen where the conversation about the prescription had happened and nobody had built a path between them. Grief without a villain is a particular kind of grief. It has nowhere to go. You can be angry at a drug dealer. You can be angry at a negligent doctor. You can be angry at a pharmaceutical company that lied. These are targets. They absorb the force of what you're feeling and give it a shape. You cannot easily be angry at a form that didn't have the right field, at a referral pathway that was 2 years long, at a clinical trial that didn't include the population it should have, at institutional distance. So the grief circled, and the families spoke into microphones, and the reports sat in the correct folders, and the advisory council continued its careful work. The structural problem underneath the prescribing problem was not a problem that reclassifying Pregabalin was going to solve. Mental health services in Northern Ireland and Scotland by the mid-decade were operating under demand they were not resourced to meet. Waiting lists for psychological therapy, a year in good areas, 2 years or more elsewhere. Addiction services, stretched, chronically underfunded, serving a population that had been growing for decades while the services had not. GPS as the de facto frontline of a mental health system that had been designed for a different level of need. The anxiety that Pregabalin was treating in both its legitimate prescription population and its opioid-dependent population was real anxiety. Not drug-seeking behaviour dressed up as anxiety. Real, clinically significant, often trauma-rooted anxiety in people who had limited access to the services that would have addressed it through other means. Restricting Pregabalin meant, what exactly would replace it? The honest answer was, in many cases, nothing. Not immediately. The therapy waiting lists weren't going to shorten because one drug became harder to prescribe. The addiction services weren't going to expand. The communities with the highest burden of trauma and opioid dependence weren't going to find those conditions ameliorated by a change to Schedule 3. This was the argument that public health specialists on the advisory council were making themselves, not on Pfizer's behalf, but because it was true. Reclassification had real costs, real harms to real patients who would find it harder to access a drug that was genuinely helping them. A person with fibromyalgia who had finally found something that worked was not going to be well served by a system that now required a physical prescription every 7 days instead of a monthly repeat. The council held this alongside the coroner's data. It weighed them. It recommended reclassification anyway, not because it would fix the underlying problem, but because it was the only available lever and not pulling it was harder to justify than pulling it imperfectly. That's how you make a decision when all the options are bad. You pick the least bad one and you live with what it costs. The Advisory Council issued its recommendation for reclassification in 2017. Pregabalin and gabapentin should become Class C, Schedule 3 controlled substances. The practical effect: physical prescription required, maximum 7-day supply, no telephone repeats, pharmacies required to maintain proper dispensing records. The recommendation was correct. The evidence supported it. The process that produced it was legitimate. It had begun in 2015. The recommendation arrived in 2017. Action would be taken in 2019. Between 2012 and 2019, from the first toxicology reports Leckie formally flagged to the moment the reclassification took effect, Scotland recorded approximately 7,000 drug deaths. Northern Ireland recorded several hundred. Not all of them involved pregabalin. A significant proportion did. The arithmetic of institutional timelines, when laid alongside the arithmetic of drug deaths per year, produces a number that the formal language of regulatory review is not designed to name. The word for it is cost, not fiscal cost, the other kind. The question of who bears it and in what proportion across GPS and pharmaceutical companies and regulatory bodies and government departments and an NHS system stretched past what it was built for, is a question the reclassification did not answer, because that was not what reclassification was for. The families had a name for what it felt like. They'd been calling it for years, into a phone at the coroner's office, into a microphone at a press conference, into a form on a government website. Nobody had been not listening. That's the hardest part. Everyone had been listening. At institutional speed, through institutional channels to institutional submissions. And somewhere in the gap, the alarm kept going quiet. During 2018, Scotland recorded its worst year on record. The reclassification was 8 months away. The council had issued its recommendation 2 years earlier. The first coroner's flags had been filed 7 years earlier. This is not an accusation. The council did its job. The government implemented the recommendation. The law changed. People who needed to change their practices changed them. This is just the arithmetic of what 7 years of institutional process costs when measured in people. There is no formal mechanism for calculating this cost. No government body publishes a figure that says the gap between the first evidence and the enacted legislation lasted this long, and this is what it cost in lives. Regulatory bodies produce recommendations. Legislative bodies produce laws. Neither produces an honest accounting of the gap between them, because doing so would require accepting that institutional timelines are a causal factor in preventable deaths, and that is an acceptance that the institutions involved are not structurally designed to make. The families made it. Not in those terms, not in the language of regulatory lag or institutional timelines, in the language of my son died in 2018. The recommendation had already been issued. The law wasn't there yet. That gap between the recommendation and the law, between the law and the community knowledge, between the community knowledge and the person who hadn't heard yet, is where most of the people in this story died. Not in the dramatic moments, in the gaps. The Pfizer question is worth sitting with properly, because it tends to get handled in 2 ways that are both wrong. The first wrong way, Pfizer knowingly let people die to protect revenue. This is a satisfying story. It has a clear villain. It is almost certainly not what happened, in the sense that it implies a specific decision was made by specific people who weighed lives against money and chose money. Companies don't typically work like that. Pharmaceutical regulatory affairs departments work by managing regulatory risk, maintaining access to markets, and protecting the competitive position of products. These are professional functions performed by professionals who are not, individually, choosing to let people die. The second wrong way. Pfizer was just doing its job and bears no particular responsibility. This is equally wrong. A company that generates $5 billion per year from a drug has documented evidence of its role in drug deaths in its pharmacovigilance system and advocates against reclassification during a regulatory review, in which that evidence is central. This is not a neutral actor. The advocacy was self-interested and had consequences. The consequences are measurable in the drug death data. The truth is somewhere that doesn't resolve into a simple story. A company with a legal obligation to advocate for its product did so in the context of a review process that was going to make a decision regardless. The review took 2 years. The law took 2 more. During those 4 years, the drug remained freely prescribable. The prescribing rates remained elevated, and the deaths continued to occur at the rates they had been occurring since 2012. The company's advocacy did not cause those 4 years to take 4 years. Institutional process caused that. But the advocacy occupied space in the process that could have been occupied by something moving faster. This is not nothing. It is also not a crime. It is instead the kind of consequence that pharmaceutical incentive structures produce when they meet public health emergencies that move faster than regulatory review cycles. The system was working as designed. The design had gaps. The gaps had a cost. The cost was not paid by the company. In 2016, a woman in Belfast gave a statement to a journalist. Her son had died the previous year. He'd been using heroin for a long time. He had also, she said, been taking Pregabalin that a friend had given him. The friend had a prescription, she explained, like he was explaining something ordinary, because to him it was ordinary. It was medicine. It came from a pharmacy. It had someone's name on it. She said her son had not seemed like someone who was in danger. He had seemed, she said, like someone who was managing. This is a word that gets used. Managing. It's the word people use when they mean not fixed, not recovered, not okay in the way that okay is supposed to look, but surviving, getting through, keeping the days moving, managing. Her son had been managing. He had been managing with a combination of things, one of which turned off the alarm that would have told him he needed to stop, and he hadn't known that, and nobody had told him, and the foil blister pack had still been on the table when she found him. The journalist wrote the story. The advisory council continued its review. Pfizer continued generating revenue from the drug. The GPs continued writing prescriptions for the patients who needed them. The coroner continued filing reports. And the question of who was going to tell the next person, the one who was currently managing, who was currently combining, who had not yet been warned, remained unanswered in a way that the recommendation, when it finally came, did not fully answer either. The recommendation changed the drug's legal status. It did not retroactively place a warning label on every blister pack that had already left the pharmacy. It did not retroactively inform every person currently combining Pregabalin and heroin that the thing they were combining was specifically, precisely dangerous in a way that neither drug alone was. It did not reach, in the months between its publication and the legislation's passage, the people for whom reaching them in those months was the only thing that would have mattered. The alarm is ringing in the coroner's files. It has been ringing for years. In April 2019, the law is about to change. The gap between what institutional processes know and what communities know has a specific texture in drug policy that doesn't exist quite the same way in other policy areas. When a bridge is found to be structurally unsound, the information travels quickly to the people who are about to drive over it. The mechanism for this, closures, barriers, diversions, is designed to work at the speed of physical risk. The information reaches the person before they cross. When a drug combination is found to be specifically, precisely, lethal in a way that hasn't been widely communicated, the information travels at the speed of regulatory process. It moves through databases, through papers, through committee submissions, through public consultations, through legislative stages. It ends up eventually in a change to the prescribing guidelines that a GP reads in a continuing professional development bulletin. The bulletin is not in the flat. The flat has the blister pack. The reclassification was the right tool. Nobody else was offering a better one. What it couldn't do was move at the speed of the problem, because nothing in the regulatory architecture was built to move at that speed. The architecture was built for thoroughness. Thoroughness takes time. Time in this particular problem had a concrete and measurable cost. April 2019 was coming, 2 years after the recommendation, 7 years after the first formal flags, and in communities in Belfast and Glasgow where the word had by now spread, through survivors, through family networks, through the community knowledge that moves faster than regulatory filings, the combination was already becoming less common. Not because of the law, because people had told each other. That information, moving through communities at community speed, had done more in 12 months than 7 years of formal documentation had done through official channels. This is not an argument against official channels. The law mattered. The reclassification mattered. What it is a description of how information travels and how much faster it travels horizontally, from person to person, in language people actually use through networks people actually trust. Then it travels vertically through institutions. The community had been trying to tell itself. The institution had been trying to tell the community. They were moving at different speeds toward the same destination, and the distance between them had been filled, in the meantime, with 7 years of toxicology reports. April 2019 arrived. Pregabalin became Class C Schedule 3. The legislation that had been recommended in 2017 and due in 2018 and delayed and rescheduled and finally enacted passed into effect on the 1st of April, a date that, if you were inclined toward the cosmic irony of things, had a particular quality to it. Pharmacies received updated guidance. GPS received updated prescribing information. The system that had been generating tens of millions of Pregabalin prescriptions per year quietly adjusted its protocols. Maximum 7-day supply per dispensing. Physical prescription required. No telephone repeats. The blister packs didn't disappear. They became harder to obtain. In communities in North Belfast and East Belfast and South Glasgow, the news of the reclassification arrived through the same channels that all practical news arrives in communities where formal information tends to show up late and in language that wasn't designed for the people who most need it. Word of mouth, texts, conversations at the corner of streets, people who'd heard from someone who'd heard from someone. By the time the law changed, a significant proportion of the people in those communities who needed to know what it meant had already developed some version of this knowledge. Not through the official channels, through the community information network that had been running, slowly and imperfectly, since the deaths had started happening often enough to become impossible to ignore. They knew pregabs and heroin was the combination to be careful about. They knew it because someone in the network had nearly died, because someone's brother had died, because the pattern had become, in the specific communities where it was concentrated, a piece of survival knowledge passed person to person in the way that survival knowledge in those communities had always travelled, not from the top down, from the side across. The grief in those communities has a particular quality that ordinary grief doesn't quite match because it accumulated in a pattern. Not one death, several, within the same network, sometimes within the same year. The person who died in the flat on the 3rd floor knew the person who had died in the house 2 streets away 4 months earlier. They had in some cases shared the same supply, in some cases the same prescription network. The surviving people in those social circles watched the pattern repeat in slow motion, knowing what was coming, sometimes unable to stop it, because knowing what the combination did and being able to stop someone from using the combination are different problems that require different solutions, and the solution that was available, warning people, was only as fast as the network carrying the warning. Communities with concentrated drug dependence develop a particular relationship with loss that doesn't always read as grief from outside. The funerals happen. People go back to their lives. The lives continue to be what they are. The conditions that produce the dependence, the poverty, the trauma, the absence of alternatives, remain exactly as they were. The grief is real. It's just that it has to coexist with everything else that's also real. There's no space to stop. There is also, alongside the grief, something that doesn't have a clean name, a kind of accumulated vigilance. Communities that lose people to a specific preventable cause develop an attention to that cause that formal public health programs struggle to replicate. The information about what Pregabalin did to the alarm was not delivered by a leaflet or a campaign or a prescribing guideline. It was delivered by people watching each other, noticing the pattern, and passing the information sideways through whatever channels were available. This knowledge came at a cost. The cost was the people who died before the knowledge was widespread enough to reach them. The GPs who had prescribed Pregabalin to patients who died with it in their system carried something that had no formal name in medical ethics and no formal procedure for processing. A GP who prescribes incorrectly, the wrong drug, the wrong dose, a documented contraindication ignored, has a process. There are clinical governance procedures. There are incident reports. There are mechanisms designed to address error, because error is a category the system is built to handle. A GP who prescribes correctly, according to the guidelines available at the time, to a patient who then uses the drug in a way the GP didn't know about and couldn't have known about, in combination with another substance the GP wasn't aware the patient was taking, with a result that killed the patient. This GP has not made an error in any technical sense. The prescription was appropriate, the guidelines were followed, the clinical decision, in the context of available information, was defensible. This is not a comfort. It is possible to have done everything right and still be part of a chain of events that ended someone's life. The GP who prescribed Pregabalin to a patient who came in with anxiety, a patient who was also using heroin, which the patient didn't disclose, or which the GP didn't screen for, because the screening question wasn't yet standard practice. This GP may have replayed that consultation many times, may still. The consultation was 9 minutes. The patient had anxiety. Pregabalin was the appropriate prescription. There is a version of accountability that medicine is reasonably good at. The investigation, the review, the finding of what went wrong, and who deviated from standard practice. There's another version that medicine has no framework for, the weight carried by a clinician who did everything the system asked of them, and whose patient died anyway, because the system itself had a gap the clinician had no way of seeing. The post-2019 screening question, "Are you currently using opioids?" would have helped. It would not have caught every case. Some patients wouldn't have disclosed. Some would have received the prescription anyway for legitimate reasons. But some conversations would have happened that didn't happen. Some combinations would have been avoided. The question wasn't asked before 2019 not because GPs were negligent, but because nobody had told them, in language that reached the consultation room, that it needed to be asked. That information was in the coroner's files. It arrived in the consultation room via a newspaper in 2019. What changed after April 2019 was measurable. Not transformative, measurable. Pregabalin prescribing in Northern Ireland dropped noticeably in the 18 months following reclassification. Deaths involving pregabalin in the same period declined, not to zero, not even close to zero. But the direction of the trend reversed for the first time since the crisis had become visible in the data. The 7-day dispensing cap made a difference. Repeat. Prescriptions had been a structural enabler of diversion. A patient receiving 3 months of pregabalin at once had 3 months of pills to manage, sell, or share. Weekly dispensing meant smaller quantities in circulation at any given time. The arithmetic of availability shifted. GPs became significantly more cautious. Not because the reclassification required them to be. The law changed the dispensing rules, not the prescribing criteria, but because the crisis had become visible in a way it hadn't been before the law changed. The regulatory attention brought media attention. The media attention reached GPS in a way that the coroner's reports, filed through official channels, had not fully reached them. This is one of the stranger facts in this story. The information that pregabalin was killing opioid-dependent people, in combination with heroin, had been available to anyone with access to the formal health literature since roughly 2013. It was in the toxicology reports. It was in Lecky submissions. It was in the public health data. Any GP who read the addiction medicine literature in that period would have encountered it. Most GPs do not read the addiction medicine literature. They read the prescribing guidelines, the drug interaction databases, and when things become significant enough to reach mainstream medical news, they read that. The formal knowledge had existed in the system for years. The human reality of it reached the prescribing community in a newspaper. This is not how knowledge is supposed to travel. It is exactly how knowledge travels. What did not change after April 2019 was more consequential than what did. Gabapentin, pregabalin's slightly less potent chemical cousin, same class, same mechanism, same suppression of excitatory CNS signaling, was not reclassified at the same time. The ACMD recommendation had covered both gabapentinoids. Gabapentin was included. But gabapentin presented a different prescribing picture. Cheaper, more widely used for conditions like restless leg syndrome and certain types of neuropathic pain, and with a larger legitimate patient population that made the calculus of restriction more complex. The practical result: people who could no longer easily obtain pregabalin shifted to gabapentin. Same class, same interaction with opioids, same mechanism of alarm suppression, different name on the blister pack. The deaths involving gabapentin began to rise in the same communities where pregabalin deaths had been falling. This is what addiction medicine specialists call structural substitution, the phenomenon where restricting one substance in a class shifts use to another in the same class, without shifting the underlying demand or the underlying risk. The drug changes, the mechanism doesn't. The harm profile moves sideways rather than disappearing. Gabapentin was reclassified to Schedule 3 in its own right, also under the 2019 regulations, but the community knowledge that had accumulated around pregabalin, the specific hard-won person-to-person knowledge of what it did to the alarm, hadn't accumulated around gabapentin yet. People knew pregabalin was dangerous in combination. They were starting from the beginning with gabapentin. The alarm goes quiet under gabapentin for the same reason it went quiet under pregabalin. The molecule is different, the mechanism is the same, and the community is learning it the same way it learned the last one. The people who died in 2018, the record year, the year the reclassification was already recommended and not yet enacted, occupy a particular position in this story that doesn't have a tidy name. They died during the gap. The evidence was clear. The recommendation was issued. The legislation was being drafted. The system was moving. 1 year away from the law that might have made it harder for them to access the combination that killed them. 1 year. The gap between the right decision and the enacted decision has a cost that is almost never formally calculated, because doing so would require accepting that institutional timelines are a causal factor in preventable deaths, and that is an acceptance that the institutions involved are not generally structured to make. But the people who died in 2018 were not abstractions. They had names that appear in coroners' records. They had families who are still alive. They died in the gap that existed between knowing what should be done and doing it, in a year when everyone who needed to act had already agreed that action was required. That gap was 1 year long. 1,187 people died in Scotland in that year from drug-related causes. Not all from Pregabalin, many from it, in the middle of a gap that was scheduled to close 12 months later. Families who lost someone in 2018, in the year after the recommendation, in the year before the law, occupy a specific position in the arithmetic of this story. They are the people the system had already decided to protect. The recommendation existed. The intent was clear. The machinery was in motion. The law just wasn't there yet. This is not unusual. 2 years between recommendation and enacted legislation is, by the standards of UK drug policy, relatively fast. The process involved Home Office consultation, parliamentary drafting, impact assessment, and the standard administrative machinery that legislative change requires. 2 years is what it takes. The question of what 2 years costs measured not in fiscal terms but in the other kind. That question sits in the coroner's records for 2018, filed under causes of death, waiting for someone to do the arithmetic that institutions are not designed to do themselves. In 2019, in the same month that Pregabalin became Class C in the United Kingdom, Pfizer's patent on Lyrica expired in the United States. This was not a coincidence in any conspiratorial sense. It was the overlap of two independent timelines: the patent protection clock, which had been running since the drug's approval in 2005, and the regulatory review clock, which had been running since the ACMD was asked to look in 2015. Both clocks ran out in the same year. The commercial consequence: generic Pregabalin flooded the market. The price, which had been sustained by patent protection at levels that generated $5 billion per year globally, collapsed. Generic Pregabalin, manufactured by multiple companies, was available for roughly 10 cents a capsule in bulk. The same molecule, the same pharmacology, the same mechanism of alarm suppression, 1/10 of $1 per dose. Pfizer's revenue from Lyrica dropped by approximately $4 billion in a single year. The drug that had been the company's second largest revenue generator became, effectively, a commodity. A profitable commodity. Generic manufacturers were making money from it too, just at much lower margins. But the specific commercial incentive that had driven Pfizer's advocacy during the review, protecting $5 billion per year of revenue from a drug facing reclassification, ceased to exist at exactly the moment the reclassification took effect. Nobody planned this timing. Nobody engineered this alignment. But from the outside, the 5 years of review, the years during which the commercial incentive to resist reclassification was at its highest, and the patent clock align in a way that is worth noting, if not naming. The drug became Class C. The patent became worthless. Both, improbably, on the same month. The communities in Belfast and Glasgow didn't experience April 2019 as a turning point, because that's not how communities experience the enactment of secondary legislation. What they experienced was a gradual shift in what was available, and at what price, and through what channels. Pregabalin became harder to get from the GP for anxiety. The new screening questions, the shorter supply windows, the increased scrutiny. A drug that had previously been obtainable in a 30-day or 3-month supply, dispensed at the pharmacy on presentation of a paper prescription, was now dispensed in 7-day quantities, requiring a physical prescription each time from a prescriber who was now being asked to consider whether the patient in front of them was using opioids. The architecture of access changed. The street supply, which had been sustained by prescription, diversion, by the gap between how much a patient was prescribed and how much they were actually taking, became thinner. A patient receiving a week's supply at a time had less to divert than a patient receiving 3 months' worth. The math of availability shifted in the direction the reclassification had intended. Some people stopped using Pregabalin. Some switched to gabapentin. Some died in the gap before any of this reached them. People for whom the community knowledge hadn't arrived fast enough, or the change in availability hadn't happened fast enough, or whose particular situation put them outside the reach of whatever protective factor might otherwise have applied. The opioid dependence remained. The mental health waiting lists remained. The anxiety that had driven the prescribing in the first place remained. What the reclassification changed was the supply side. What it didn't change was the demand, because drug policy doesn't have a tool for that. GPS in Northern Ireland and Scotland in the years following reclassification adopted screening for opioid use as a standard part of the gabapentinoid prescribing conversation. A question that had not been standard practice, "Are you currently using or have you recently used opioids?" became routine. Better late. The knowledge had existed for years. The reclassification created a moment of professional attention that moved it from the database to the consultation room. The conversation between the person with the prescription pad and the person with the anxiety, the conversation that could have made a difference from the beginning, was finally happening. In the communities themselves, a parallel process had been running independently. The people who survived the combination became, informally, a resource. They knew what the not knowing felt like from the inside. They told people. Communities that lose people to a specific cause develop a hard-won competence around it. Practical, embodied, spoken in language people actually use through networks people actually trust. It works slowly. It is expensive in terms of who has to die first, but it works. The alarm that Pregabalin had switched off in individual nervous systems had been replaced slowly by a community alarm, a collective nervous system that had learned through accumulated loss what this combination cost. It was a more expensive way to learn it. The community alarm worked differently from the individual one. The individual alarm was bodily, a physical signal refined over years of use that said, "Stop here." The community alarm was social, a piece of knowledge moving through a network, arriving in conversations, in texts, in the specific advice that people give each other when they've seen something go wrong and want to prevent it from going wrong again. Both worked. Both were imperfect. Both arrived too late for some people and in time for others. The difference is that the individual alarm was something Pregabalin specifically disabled. It targeted the exact mechanism that experienced users had developed to protect themselves. The community alarm, being social rather than neurological, was out of Pregabalin's reach. You could silence the signal inside one person's nervous system. You couldn't silence what their friends knew, what the story of Pregabalin and heroin in Northern Ireland and Scotland actually demonstrates. If you pull back far enough to see the whole arc, rather than any single decision within it, is not primarily a story about a bad drug, or a negligent regulator, or a cynical pharmaceutical company, or reckless users. It is a story about the distance between databases. The prescribing database and the coroner's database were in different buildings, maintained by different institutions, read by different people, in different professional cultures, speaking different languages. The prescribing data said, "This drug is being dispensed at this rate, in this postcode to patients with these conditions." The coroner's data said, "This drug is appearing in toxicology at this rate, in this postcode, in combination with this other drug, at these concentrations." Both data sets were accurate. Neither talked to the other automatically. The connection between them had to be made by a coroner who noticed a pattern, wrote a formal report, submitted it to the appropriate department, and then continued to do this for 3 years before anything that resembled a response arrived at institutional speed. John Leckie in Belfast made that connection. He made it carefully, repeatedly, in the correct format, through the correct channels. He was not ignored, he was received. The response moved at the speed of institutional response, which was not the speed of the problem. That gap between the coroner's filing and the regulatory action is not a gap that appears in the toxicology report. It doesn't show up in the prescribing data either. It lives in the years between the first formal flag and the last death that might have been prevented by faster action. The electronic health record systems that would eventually make it easier for a prescriber to see a patient's full medication and treatment history, including treatment they were receiving elsewhere in the system, in an addiction medicine clinic or a mental health service or a hospital, were, by 2019, in various stages of development and implementation across NHS services. Not complete, not fully connected, not yet capable of telling a GP in North Belfast in the 9 minutes of a consultation that the person in the chair was also receiving methadone from an addiction service 2 postcodes away. But being built. The goal, a single view of a patient that crosses the boundaries between different parts of the same healthcare system, is not technically difficult. It is institutionally difficult. It requires the organizations that have developed their own systems, their own data structures, their own cultures of information management, to agree on a shared format and a shared set of rules about who can see what and when. This takes time. It takes political will. It takes funding. It is being built, in part, because of what the gap between 2 databases in 2 buildings had cost. The databases don't count those years. The families do. They have been counting since 2012. Pregabalin is still here. It did not disappear when it became Class C. It didn't disappear when Pfizer's patent expired and the revenue collapsed. It didn't disappear when Scotland recorded its worst year and Northern Ireland's coroners filed their 1000th report. It is here, today, in NHS pharmacies across the United Kingdom, being dispensed legally to people who need it, for reasons that are medically sound. It is treating nerve pain in people with diabetes for whom other medications have failed. It is treating epilepsy in people for whom seizure control is the difference between a functional life and a dangerous one. It is treating fibromyalgia in people who spent years being told their pain wasn't real, and for whom the drug that finally took it seriously enough to prescribe something for it is the first meaningful relief they have had. It is still, in some proportion of cases, being combined with opioids by people in communities where opioid dependence remains high and the tools for addressing it remain inadequate. The blister pack still looks like medicine, because it still is medicine. The global picture of Pregabalin in 2024 is one that the story of Belfast and Glasgow makes legible in a way it wouldn't be without that context. The drug is now generic. The price has collapsed. In countries where it was previously expensive, it is now cheap. This is, on balance, good. More people who need it for legitimate therapeutic purposes can access it. The expansion of access to off-patent medicines is one of the few pharmaceutical dynamics that consistently benefits patients rather than companies. It is also, in countries where opioid dependence is concentrated alongside newly cheap Pregabalin, the same structural setup that produced the crisis in Northern Ireland. Different geography, same arithmetic. Finland has documented significant Pregabalin misuse in opioid-dependent populations. Parts of the Middle East, Bahrain, Lebanon, have recorded similar patterns. In these regions, Pregabalin arrived cheaply and widely before the community knowledge about its interaction with opioids had time to develop. The lesson that Belfast and Glasgow learned through accumulated loss had not yet been learned there. The same combination, the same pharmacology, the same silencing of the alarm. The United States, where gabapentin is scheduled in some states and pregabalin has been Schedule 5 since 2005, is watching gabapentinoid misuse rates in opioid-dependent communities with the particular attention of a country that has already learned, at considerable cost, what happens when it doesn't watch closely enough. The opioid crisis that defined American public health for 2 decades produced the surveillance infrastructure and the prescribing culture awareness that might mean the Pregabalin story in the US looks different from the Pregabalin story in Belfast. Or it might not. Structural conditions matter more than awareness. A drug that is cheap, legally available, and addresses a real need in a population with limited access to better alternatives will find its way into that population, regardless of whether the warning is technically available somewhere in the prescribing literature. The pattern doesn't repeat identically. But the pharmacology is the same everywhere. The calcium channel suppression is the same. The quieting of the bodily alarm is the same. The alarm doesn't know which country it is in. What the Pregabalin story added to the existing knowledge of pharmaceutical harm. The literature that had accumulated through OxyContin and fentanyl and benzodiazepines, and before that the barbiturates, and before that, whatever the previous generation's version of this had been, was something the existing literature had not quite captured in this form. The existing literature knew about additive CNS depression. It knew that opioids plus sedatives equals more respiratory depression. It knew this in pharmacological terms, in the language of synergism and threshold effects and receptor kinetics. The knowledge was in the textbooks. It was in the prescribing guidelines, in the fine print, in the contraindications section that most patients and many prescribers treated as background noise. What it didn't fully describe, what the Belfast coroner's data added to the picture, what the survivor accounts confirmed, was the mechanism from the inside, not the pharmacology, the experience. Experienced opioid users had a survival tool that was not in the textbooks because it wasn't a pharmaceutical intervention. It wasn't something a clinician had prescribed or a researcher had measured. It was bodily. A sense built over years that said, "Here is the line. Stop at the line." The line had kept people alive who would otherwise have died. In a population with limited access to formal harm reduction services, limited access to naloxone, limited access to supervised consumption facilities, in a population for whom the formal safety infrastructure of opioid dependence management was chronically underfunded, this internal instrument was often the primary safety mechanism available. It was not a small thing. It was for many people the only thing. Pregabalin removed it. This is a different kind of harm than this drug is dangerous. It's a harm that specifically targets the adaptive safety mechanism that people at high risk had developed in the absence of better institutional support. The people who had the best developed alarm systems were the people most at risk of having them disabled, because they were the people most likely to be combining pregabalin with opioids. The drug was specifically harmful to the people who had most successfully compensated for its absence of formal support. That's a particular kind of cruelty, even if it was an unintended one. There is something that addiction medicine researchers call the regulatory lag problem, a pattern that recurs with enough regularity that people who study drug policy have a phrase for it. A drug enters use. The population for whom it is harmful develops harm at a rate that produces a signal in the data. The signal takes time to be detected, and more time to be formally documented, and more time to reach the regulatory body, and more time to complete the review cycle, and more time to pass through the legislative process. By the time the response arrives, the harm has been accumulating for years. In the case of pregabalin, 7 years. In the case of OxyContin, closer to 20. In the case of benzodiazepines, the lag is still running. The jobs, done well, take the time they take. The people who died in Northern Ireland and Scotland during those years died quietly. This is the detail that stays, not dramatically, not in ways that announce themselves as emergencies. They died in the specific private way that Pregabalin made possible. The breathing slowing past the point of return in conditions of calm, without distress, without struggle, without anything visible that said, this person needs help, something is wrong, something has gone past where it should have gone. The alarm that experienced opioid users had built over years of careful, cautious, survival-oriented use simply was not there. It had been quieted by a drug that came in a foil blister pack with a patient's name on it, prescribed by a GP in a 9-minute appointment, dispensed by an NHS pharmacy, reimbursed by the government of the United Kingdom, generated by a company headquartered in New York and listed on the stock exchange, approved by the European Medicines Agency in 2004 and the Food and Drug Administration in 2005 and the NHS prescribing formulary in due course. Everything in that chain was doing what it was supposed to do. The people who died had done what they were doing, which was trying to manage an extremely difficult condition with the tools available to them, including a drug that turned out to have a specific and lethal interaction with one of the other tools they were using. They were not reckless. They were not ignorant of risk in some general sense. They were experienced. They had been navigating the specific risks of opioid dependence for years with a precision that people outside that experience rarely recognize as precision. They just hadn't been told about this particular risk, the particular, quiet, unannounced risk of taking a drug that would switch off the thing keeping them alive while producing no sensation that anything had been switched off. The drug is still here. The interaction is still here. The awareness is better now, in the prescribing room and in the community. The law is better now. The architecture of access is tighter. The question that GPS now ask, are you currently using opioids, is being asked in consultation rooms where it was not asked before 2019. These are real improvements. They arrive through real losses. The alarm. For someone who takes Pregabalin tonight alongside heroin for the first time, in a city where opioid dependence is high and the word hasn't fully spread, and the GP didn't ask the right question, and the pharmacist dispensed correctly, and the blister pack looked like medicine, because it was medicine, the alarm for that person is the same alarm it was in 2012. Quiet. Not because the drug changed, because the drug never announced what it was going to silence. John Leckie eventually retired. The toxicology reports on his desk were filed correctly in the appropriate place. The pattern he identified is now in the formal literature of drug-related harm. Medical students studying pharmacokinetics learn about gabapentinoid and opioid interactions as a documented and serious risk. Prescribers in Northern Ireland and Scotland screen for opioid use before reaching for the Pregabalin prescription. The information that Leckie spent years trying to move from the coroner's office to somewhere it could do some good is finally in the places it needed to be. The system is better than it was. This is true. It is worth saying plainly without irony. The system is better than it was in 2012. The information that took 7 years to move from a coroner's desk to a prescribing guideline is now in the prescribing guideline. The question that wasn't being asked is now being asked. The reclassification that took until 2019 is now enacted. These are not nothing. The coroner's office in Belfast still receives toxicology reports. Most of them do not involve Pregabalin. Some of them do. The pattern continues. The blister pack still looks like medicine. The prescription system still generates prescriptions. The NHS still provides what it can with what it has, which is not always quite enough. The mental health waiting lists are shorter than they were in 2012, but not short. The addiction services are better funded than they were, but not adequately. The communities in North, Belfast and South Glasgow are not the communities they were in 2010. Some things have improved, and some things have not changed at all, and some things have gotten worse in different ways. And Pregabalin, the molecule that Richard Silverman synthesized in 1990 in Illinois while looking for something else, that Pfizer named Lyrica after the sound of gentle music, that $5 billion a year confirmed as one of the most commercially successful pharmaceutical discoveries of its era, that John Leckie identified in his toxicology reports and flagged formally, and waited for the response. Pregabalin is in a pharmacy near you. It is helping someone sleep through pain they've had for years. It is allowing someone to leave the house today who couldn't leave it yesterday. It is somewhere, right now, doing exactly what it was designed to do. And it is somewhere, in a combination that nobody in that chain intended, doing the other thing, the quiet, unannounced thing, going quiet. The alarm isn't ringing. That's the thing about Pregabalin and the alarm. You don't know the alarm has stopped until it's too late to miss it. The regulatory lag problem doesn't stop with Pregabalin. By the time Pregabalin was reclassified, the same structural setup was already producing the same pattern with gabapentin. The populations most likely to encounter pharmaceutical drugs in combination with other substances are often the populations least likely to be included in the clinical trials that determine safety, because including them requires testing drugs on people using illegal substances, which ethics committees do not approve. The knowledge gap between the tested population and the actual population is not an error. It is a predictable consequence of how clinical trials are designed. It produces predictable harm. Pregabalin is one drug. The pattern is pharmaceutical history. The next version of this story is already accumulating in some coroner's office, in some city, in toxicology reports that have not yet been read in sequence by someone who will notice what they have in common. The opioid crisis, whichever version of it you're describing in whichever country across whichever decade, has a recurring structure that Pregabalin's role in Belfast and Glasgow fits into almost perfectly. A population in pain, a pharmaceutical solution that addresses that pain, not perfectly but measurably, at a price, and with an availability that make it accessible. A mechanism of harm in the interaction between that solution and the thing the pain was produced by, and a gap between the harm being visible in one part of the system and the information reaching the people experiencing it, filled for the duration of the gap with the people who died in it. Pregabalin didn't create this structure, it fit into it. The structure was already there, assembled from the post-conflict trauma and the opioid dependence and the mental health waiting lists and the prescribing incentives and the regulatory timelines and the pharmaceutical revenue and the databases that didn't talk to each other. Pregabalin arrived into a context that had been prepared for it by decades of underinvestment in the communities where it would do its worst damage, and by a pharmaceutical development system that was not designed to anticipate what would happen when a drug approved for one population encountered a completely different one. The blister pack looked like medicine because the thing in the blister pack was medicine. The problem was never the medicine. The problem was the gap. Richard Silverman, the chemist at Northwestern University who synthesized Pregabalin in 1990, while looking for something else, gave an interview some years after the drug's commercial success became evident. He expressed genuine surprise at the scale of the drug's uptake. He had been researching anticonvulsants. The molecule had shown promise for pain. He had not anticipated fibromyalgia approval, or generalized anxiety disorder approval, or $5 billion per year, or blister packs in Belfast. He expressed concern when interviewed about the misuse reports, that the drug had caused harm he had not intended. This is the most honest thing that can be said about Pregabalin by anyone in the chain, from synthesis to street. Nobody intended the harm. The synthesis was science. The development was business. The approval was regulation. The prescribing was medicine. The diversion was economics. The combination was survival. The death was pharmacology. Every step in the chain was someone doing something that, from inside their role, was rational, defensible, sometimes genuinely beneficial. The chemist was doing chemistry, the company was doing business, the regulator was doing regulation, the GP was doing medicine, the patient receiving the prescription was doing what patients do, taking a medication that a doctor said would help. The person who shared the blister pack was doing what people in tight communities do when someone they know is in pain and they have something that helps. The gap between all those rational, defensible, sometimes genuinely beneficial steps was the space where the alarm went quiet. Not because anyone put the alarm there, because the alarm was the only safety system that the people at the end of the chain had, and it was the one thing that nobody's rational, defensible action had made provision for. It was built by survivors in the absence of better options, out of the material of their own nervous systems. It worked. Until Pregabalin. The word that keeps appearing in the accounts of families from this period is ordinary. The day was ordinary. The person was doing what they ordinarily did. The drug was one they ordinarily used. The combination was ordinary. Nothing was extraordinary about any of it until the moment it became extraordinary in the only way that matters, which is that it became the last thing. Ordinary is the word families use when they mean nothing told us. Nothing announced it. There was no warning signal that this day was different from any other day. There was no sound of an alarm. The alarm was quiet. This is the specific cruelty that Pregabalin added to an already difficult situation. Opioid-dependent people and their families had learned to live with a particular kind of risk. The risk that a dose might be too much, that purity might vary, that something might go wrong. They had adapted to this risk. They had built systems around it, informal ones, but real, checking on each other, keeping phones close, watching for signs. Pregabalin removed the signs. The body's response to respiratory depression normally produces visible distress. The face changes. The breathing becomes audible. Something in the person's appearance announces that something is wrong. Family members who have found people in overdose situations have sometimes intervened in time. The naloxone programs that exist in communities with high opioid use depend on this, on the idea that overdose has a window, a visible moment where reversal is possible. Pregabalin closed that window, not by killing faster, by killing silently. The breathing slowed without any of the signs that would have prompted intervention. The families who found their people described them as looking peaceful, looking like they were asleep. Nothing about the scene announced what had happened until it was too late to do anything about it. The alarm is the thing this story keeps returning to because it is the most precise description of what was lost. Not the person, though the person was also lost, and that loss is its own complete thing, but the specific mechanism, the specific bodily, survival-oriented mechanism that experienced people had built, and that Pregabalin quietly, without announcement, removed. The drug that did this was not a poison, it was not a weapon, it was and remains a medicine. It was a medicine that, in a particular combination, quietly and without announcement removed the thing that was keeping people alive, the alarm, which for some of them simply never sounded. There is an ongoing project in several research institutions in the United Kingdom and elsewhere to develop what pharmacologists call a next-generation gabapentinoid, a molecule that provides the anxiolytic and analgesic benefits of pregabalin without the broad excitatory suppression that makes it dangerous in combination with opioids. The target is a drug that quiets the right channels without quieting the alarm. This is technically difficult. The calcium channel subtypes involved in producing therapeutic benefit, and the subtypes involved in producing the alarm suppression overlap significantly in the current molecule. Separating them cleanly requires a level of molecular precision that Pregabalin, designed in 1990 with the tools available in 1990, was never going to have. Some researchers think the separation is possible with newer synthetic approaches. Some think the benefit and the risk are inseparable in this class of drugs, that the anxiolytic effect and the CNS depression that enables it cannot be architecturally divided, and that the better answer is better screening, better prescribing culture, and better community information rather than a better molecule. Both research programs are running simultaneously. This is not unusual in pharmacology. The field rarely resolves questions before multiple competing approaches have had the opportunity to fail or succeed. Both are funded in part by the lesson that Pregabalin taught, the lesson that a drug can do everything it was approved to do and still produce a harm that nobody in the approval process anticipated, because the population that would experience the harm was not the population that the approval process evaluated. The lesson cost what it cost. It is at least being applied. Pregabalin is still here, still prescribed, still cheap, still providing genuine relief to millions of people worldwide for whom the drug works as intended, and causes no harm beyond its expected side effects. Still, in some proportion of prescriptions, finding its way into populations for whom the combination risk is real. Still, in those populations, in those combinations, capable of doing what it has always been capable of doing. Quieting the alarm, the blister pack still has a patient's name on it. The GP who signed the prescription is still doing their best with the information and time available to them. The pharmacist who dispensed it is still operating within the correct protocols. The NHS is still providing what it can. The alarm is still the thing nobody mentions on the label. Because the label was written for the patient the drug was approved for, the person with nerve pain or epilepsy or fibromyalgia or anxiety, sitting in a GP's waiting room in an ordinary part of a city, managing an ordinary condition that the drug is genuinely suited to treat. For that person, Pregabalin is what it says it is. The label is accurate. The drug does what it's supposed to do. The label was not written for the person 2 streets away who is going to receive the blister pack from someone who didn't need all of it, and who is going to swallow a capsule alongside something else, and who is going to wait for the internal signal that says stop here, this is the line, and not hear it. Not because the line isn't there, because Pregabalin moved it without telling anyone, and that, as far as this story can tell it, is where we are. The drug is in the pharmacy, the alarm is at risk, the blister pack looks like medicine. It is medicine. And that's the whole problem, and the whole story, and the whole ordinary, quiet, unannounced truth of it.